Welcome, everybody. I would like to thank you all for attending. It is my unique honor and privilege to welcome you all to the second annual Global Health Summit. I would like to extend a special welcome to Dr. Donnay, and thank you for speaking, Dean Buchans, Dean White, Dean Johnson, our community partners, faculty, staff, and students. This is a really exciting event, and to give you a little bit of background, the idea for this summit was conceived in the fall of 2011. And for those of you who were here last year, you attended the first iteration of it. And the reason for this event was, as a student government, we were searching for an idea or a gift for the school's 100th birthday. And so we tossed around the idea of inviting speakers or hosting a special event. But what we ultimately realized is that the best way to honor a school that has been giving to students and community and faculty for 100 years is to give them a gift that will last for hopefully 100 years. And we wanted to start a summit that will sort of bring partners from the city, bring speakers from the bring speakers from around the world, and really help the students and faculty and staff get exposed to public health and global health, public health, all kinds of health issues from around the world. That is the idea. I mean, this school is a school of global public health, and this event sort of symbolizes that and bringing everyone's worlds together. So without much further ado, I'd like to turn the mic over to Dean Buchans. He will be introducing our speaker today. So thank you.
Thank you very much, Anup, and thank you, students, for organizing this. This means a lot to us at the school and a lot to me, because you know that we're trying to define global health as linking what's happening domestically and here in New Orleans to what's happening in the rest of the world. And the program of this summit is exactly doing that. So this is really extremely encouraging and helping us to continue to globalize the school. So thank you for doing that. Thank you, France, for accepting to come to speak today. Dr. France Donnay is OBGYN, MPH. We trained together in Brussels in OBGYN a few years ago. And France went on to do clinical work first, and then embarked into a really global career, mostly in UN organizations until she joined the Gates Foundation. She was at UNICEF for some time, and she was special at UNICEF because she was really advocating for actions to reduce maternal mortality in an agency which was very focused on children, which is important, of course, but she added the maternal side to that. Then she moved on to UNFPA, where she moved up the ranks, and at the end of her tenure at UNFPA, she was the head of the Pakistan office of UNFPA. A very, very important position, of course. She decided then to move on to something different, and she was recruited by the Bill and Melinda Gates Foundation, and where she is now the Senior Program Officer for Maternal Health. So the maternal health team is the constant here in this career. France is also adjunct professor here at the School of Public Health and Tropical Medicine, and it's always a pleasure to have her back, France.
Good afternoon, everyone. Thank you, Claire. Thank you, for the invitation. It's particularly exciting to be to come back here as part and to be part of this student summit. I was really pleased that we could arrange that. And I'm going to talk about maternal health from a global perspective. It's a global problem, but of course it's a more challenging problem in some part of the world. I just wanted to say that I will try in the next 30 minutes or so, a little bit more than 30 minutes, I will try to tell you what we do in maternal health at the Gates Foundation, what we do, and also a little bit how we do it. And of course, I will be looking forward to your questions. Just to begin with, I just wanted to make sure that everybody knows what maternal health entails, what it covers, and actually it's the health of pregnant women during pregnancy and during childbirth. So of course a maternal health or maternalist, a maternal health expert would work very closely with colleagues who focus on family planning and colleagues who work on neonatal health. So it's really the health of pregnant women once they are pregnant, but of course what happens before pregnancy and what happens to the mother and the baby after childbirth is very important as well. I wanted to start with a chart about the foundation. How are we organized? So you see from the top here that our co-chairs, of course, are Bill and Melinda Gates, and also Bill's father, who is 86 and comes every day almost to the foundation. We have a CEO, Jeff Rakes, and we have a group working on communications and operations. And we are organized along 4 main departments. The first one, on the left-hand side, the US programs, actually works on education in the US. We don't work on health and other topics in the US. We work with particularly college, high school education. Then we have the global health, which is really organized along diseases, types of diseases, and that's the blue box underneath it. So neglected infectious diseases, diarrhea problems, pneumonia, malaria, tuberculosis, and HIV. And we have functional groups that work with those teams who are working on those diseases. We have functional groups that are called discovery and transnational sciences, vaccine development, and integrated development. This is the discovery group. This is the group that works on upstream science, vaccines, and development of new vaccines and new drugs, etc. Then we have the global development group that works more on delivery, the products and the new products and drugs and vaccines that the discovery group would have discovered. So the global development groups include family health, that includes maternal, newborn, child health and nutrition, and as you see, so maternal health is part of that family health division, and family planning. Then polio, a very important issue at the foundation. You know, Bill wants to contribute to eradicate polio in the next few years, hopefully. Then we have global libraries, so computers and libraries in the global world as opposed to the US. Emergency response, a relatively small group, water, sanitation and hygiene that focus on toilet, the new toilet, trying to, not that much water, but toilet. And then agriculture is a very big department, and financial services for the poor that works on mobile money, using mobile banking for poor people. And finally, we have the global policy and advocacy group that is working on advocacy and policy with US governments, with European governments, with other governments. We have an office in London, we have an office in Washington, D.C. as well. And we have also a few offices in what is called still, but it will change, I think, developing world. So we have a big office in Delhi. We have an office that is smaller in China, and then we have now, and that's new, 3 small offices in Africa, in Nigeria, South Africa, and Ethiopia. And those offices are more external relations offices at this point, as opposed to the India office that is really involved in not only relationship with the Indian government, but also implementation of programs. And as you can see, we have a small tobacco. Okay, so we we're going to talk about maternal mortality, reducing maternal mortality, so reducing deaths during pregnancy, childbirth, and the first 6 weeks actually following childbirth. That's the definition of maternal death. Of course, we know that the problem is more challenging in Africa and in South Asia, but the problem exists everywhere. We have maternal deaths everywhere, but the rates and the numbers are very different. And that's what the next slides show. It's really a view of the world according to the size of a problem, and of course, Africa and Sub-Saharan Africa in particular, and South Asia, so India, Pakistan, Afghanistan, Bangladesh, Nepal, are really where the problems are the most challenging and the most are the focus of our program. So that explains why we work, particularly in Africa and India, and even in a relatively small number of countries that I will mention in a minute. But of course, the problem exists as well all over the world. It's a global problem, and we also have an initiative in Central America and Mexico called the Mesoamerica Health Initiative that you probably have learned about. What is exciting is that the number of maternal deaths has reduced quite strikingly since it's between 1990 and 2011, and it's estimated that in 2011 there were 270,000 maternal deaths in the world, including a sizable proportion that are linked to HIV. So you have about 50,000 deaths linked to HIV. That's called an indirect death. There are direct deaths caused by medical conditions that are related to the pregnancy, and I will show them in a minute. And then indirect deaths are maternal deaths, again during pregnancy and childbirth in women who have another condition that is aggravated by pregnancy. That condition could be HIV, malaria, tuberculosis, another one. Could be also a complication from a cesarean section. So we have direct and indirect deaths, and in fact the proportion of indirect deaths is increasing within the whole number of maternal deaths. But as you can see, there has been an important reduction. The reasons for that reduction of maternal mortality are still discussed and investigated. We can say that economic growth and better education for girls and women, better access to employment for women play an important role. Family planning programs also play a very important role in the reduction of maternal mortality, but also maternal health programs, and in particular access to emergency care in case of complications, has increased all over the world and is playing an important role. Pregnancies and deliveries are attended by skilled people more than before, and that's also helped reducing the numbers. I must say also that that reduction is also linked to other methodologies to estimate the number of deaths. This is an estimation because we don't have vital registrations in many places, so we estimate the number of deaths, and the methodologies for those modeling and estimations have changed and have improved, and that's why we came up to better numbers. What is even more exciting, and I will talk a little bit about that, is that now there is a discussion in this coming months, there is a discussion about an end game for maternal mortality. So we can see, maybe, we can predict that it would be possible to reduce the number of maternal deaths in South Africa, in Sub-Saharan Africa and South Asia, to levels that would be commensurate with the level reached by developed countries, so about 50 per 100,000 live births. So it is maybe possible to achieve that goal by 2030, 2035, so most of you will contribute to that, and that's very exciting. So the end game for maternal mortality as well as child mortality is maybe in sight. I just wanted to show a similar reduction for child mortality. As you know, from about 12 million children's deaths in 1990, we now estimate that we have about 7 million deaths in children. So it's a decline that is important, but within that childhood mortality, there is the neonatal mortality, so the death of babies in the first months in life, and that neonatal mortality is decreasing as well, but at a rate that is slower than child and maternal mortality. So there is a focus on the first months of life that needs to happen more than it is the case before. And in particular, the first week of life, because many newborns actually die in the first few days, the first week of their life, and then in the first month. So it's important to focus on neonatal mortality as well. Neonatal mortality is now 40-45% of child mortality, child being under 5 mortality. As mortality is decreasing, it's important to focus on morbidity. So morbidity is a number of conditions that women have, acute condition or more chronic condition that affect women because of pregnancy, because of delivery. And we are now working on morbidity, the definition, the criteria for morbidity. It's a complex problem, but what we know is that the number of maternal deaths is just a fraction of amongst the number of women who are actually affected by pregnancy and childbirth. There is here on this slide, as you see, a sort of a ratio 20 long-term disability for one death. This ratio 20 to 1 is really a guesstimate. Is really something that we would like to estimate with more accuracy and more rigor, and that's why we are working with WHO and partners to try to define and then to assess the number of maternal morbidities that are the consequence of bad care or insufficient care during pregnancy and childbirth. For both mothers and newborns, the risk of mortality is highest around the time of birth. It's really the day of the delivery and the few days thereafter that are the time for many maternal deaths and newborn deaths, as well as stillbirths. By definition, stillbirths happen in the last trimester of pregnancy and during the intrapartum period, so during labor and childbirth. So therefore, we want to focus on that particular time of birth. So this is another illustration of this notion, which is that amongst maternal deaths, 75%, about 3/4, happen at the time of childbirth, during labor and birth in the first 24 hours. And for stillbirth, intrapartum stillbirth, so stillbirths happening during labor, are about 50%. Half of the fetal deaths happen at that time as well, and for neonatal deaths is 25%. So the time of delivery and the first few days after that, it's a key time for access to care and good counseling and good care. If we look at what is called the continuum of care, or the continuity of interventions that and interactions between families and the health system that should happen during that period, before pregnancy, family planning, contraceptive prevalence, during pregnancy and after childbirth, we see that there is a very difference. There is many differences between the coverage of those interventions. So family planning has a coverage here of 25%. Antenatal care is achieve about 80%. 80% of pregnant women goes at least one time to an antenatal care consultation. It's less for several antenatal care visits, but the coverage of antenatal care is relatively high. Then skilled attendance at birth is about 50%, and you see the sharp decline for postnatal care. In other words, people go in and out of care, and particularly poor people. This is a slide a little more complicated, but explain the same thing. People move in and out of care according to the strengths of the program, in fact. And if we look at the peak here, you can see that family planning is relatively successful, although there is a need to strengthen the family planning programs, and you may know that the foundation and Melinda Gates in particular has chosen family planning as her main focus for the next 10 years. So, of course, the family planning programs needs to be strengthened. More women need to access contraception. Then you have a peak, again, around neonatal tetanus immunization, and then a decrease in attendance in coverage of other interventions, and then another peak around immunization. And then I think that's something that reflects the strengths of the public health programs in the past and now. And as you know, immunization, vaccinations was extremely successful in the 80s, 90s, and the early 2000s, and then HIV programs got a lot of attention and resources. So we see those programs as stronger than the other programs, the maternal care programs, the neonatal care program. So there is a lot of discussion about integrating those programs and taking advantages of the ones who have the resources and helping integrating those interventions and increasing the coverage of all interventions. But that's difficult and that's challenging. But now I just wanted to just summarize what the MNCH strategy at the foundation is. So each of those teams that I show you at the beginning, HIV, tuberculosis, family planning, nutrition, water and sanitation, each team develops a strategy every 5 years, and actually has an assessment and a review process of those strategies annually every year. But every 5 years, we really think about what we should invest in and what should be the focus of our investments and partnerships with implementing agencies and research group. In 2009, we developed the first maternal newborn child health strategy, and we decided to focus on a few conditions that are the causes of maternal and neonatal deaths, the main causes, and I will show them in the next slide. We organized the strategy around 4 initiatives. The first one is the development of tools and drugs and technologies that would help increase the coverage of those interventions that I showed. We decided to focus on delivering interventions in the community, in the home, and in first-level clinics, as opposed to working with district hospitals and above in higher levels of the health system. We thought that enhancing the number and the quality of interactions between poor families and frontline workers was key in increasing the coverage of those interventions. And we selected key geographies. We selected big countries, India, and particularly northern India, Ethiopia, and Nigeria, and particularly northeastern Nigeria. We are now going to work in Malawi as well. So we have 4 countries of focus, which doesn't mean that we work only in those 4 countries. We also have research projects in many other countries where there are research sites that are active in Ghana, in Tanzania, in Bangladesh, etc. We have many research projects that are working in other countries, but for program implementation, we focused on those 4 countries, India, Ethiopia, Nigeria, and then Malawi. So the main causes of maternal and neonatal death are as follows. So for mothers, hemorrhage is still the first cause of death in most of the world, about a third, about 25 to 30%, except in Latin America, where preeclampsia or hypertension in pregnancy has become the first cause of death. In many other places, hypertension comes second at 15%. Maternal sepsis or infections are responsible for about 10% of maternal deaths, and then obstructed labor or dystocia or difficult labor, about 10% as well. The foundation does not invest in programs looking at safe abortion. We do invest a lot in family planning and in post-abortion care, as well as maternal and neonatal care, but we don't support programs that offer safe abortion. That's why we have focused on those 4 causes of death that together contribute to about 60% of maternal death. For newborn, the main 3 causes are prematurity, that is becoming a very important cause of matter of neonatal death, but also of child death. Prematurity is almost the first cause of child death, after the second one, after pneumonia. And then neonatal sepsis, so infections in newborns, first months of life, and finally birth asphyxia, which results from a labor and a delivery process that is not going well and is not being addressed, is not being managed in a good way. And finally, as I said, there are also stillbirths that are to the neonatal death, so about 2.6 million stillbirths and about 3 million neonatal deaths. So we looked at all the interventions that could be delivered during pregnancy, childbirth, and the first week and months of life. We listed them, and we decided to work with partners in order to increase the coverage of those interventions, some of which have to be delivered to women and some to newborns directly. So the one in light brown are for women, mothers, and the one in blue are for newborn. I will not list all of them, but the idea is that those interventions have to be delivered, that we also often think that they should be delivered in facilities, but in fact they can also be delivered at home or in small clinics. So we tend to push those interventions down the level of the health system. We tend to support task shifting, which means that instead of doctors, you have nurses or even deliver a lot of interventions. And there is even a trend now towards thinking that women can actually self-assess, assess themselves, assess their own health, and maybe as individuals, but certainly in groups, can deliver interventions or check check the pregnancy, check their own blood pressure. So the antenatal and postnatal care periods are conducive to sort of a collective health interventions, and that's a relatively new thinking. And it's of course it's also supported by the development of communications, the mobile health, etc. You can imagine that the way we actually access healthcare is changing. And the strategy was already 5 years ago thinking about delivering those interventions in the home and in small clinics or in groups. We have a model of impact or theory of change that says that posits that through 4 initiatives, and I talked about the first one, I will talk about the other one in a minute. Through those 4 initiatives, we will enhance, we will strengthen, we will improve interactions between frontline workers who could be community health workers, but could be also nurse midwives or physicians, provided that they are the first point of contact between the family and the health system. So the interactions between families and frontline workers will be better, will be more frequent, will be more efficient, and will be more equitable. In other words, poor people will also be reached through those better interventions. Therefore, the interactions between the coverage of key high effective interventions will be increased, and therefore mortality will be decreased. And the strategy has set up goals for reduction of mortality in those 3 countries, and I will show them. So we are responsible to contribute to reducing mortality in those places. We don't think that the foundation and its partners will solve the problem of India or Nigeria. No. We work with partners, we work more and more with governments and partners, local partners, national partners, but we want to contribute to reducing mortality in those places. The 4 initiatives, I described the first one, which is around tools and technologies, and I will give you examples of those. The second one is about demand from communities. You're really working with communities to make them better aware of what they should expect actually during pregnancy and childbirth, what they can demand, and also promote health practices by the communities and families themselves. The third one is helping frontline workers do what they are supposed to do by providing job aids, by providing mobile trainings, by providing a lot of in-service support and supervision. findings, the results of all those work, all this work in 3 and more countries, and summarizing those findings, working with policymakers for them to change policies and allocate more resources to maternal. So in India, for instance, we work, as I said, we have a very big office in India, and the India program is becoming more and more national. It's really in the hands of the government and the national partners. We are taking advantage of a scheme. There are several schemes in India, but one focused on maternal and neonatal care. It's a financial scheme that provides small stipends or small amounts of money to poor families for them to deliver in hospitals. And they are going to facilities to deliver babies in India, to the point that the facilities are a little bit overburdened, overstretched. But that's a very interesting movement. And in India, we think that we could, in 5 years, reduce neonatal mortality by 25-30%, and reduce maternal mortality by 15 to 25%. So that is supposed to come in 2014. And indeed, maternal and neonatal mortality has been decreasing in India. In Ethiopia, we have a similar platform, actually, that's less based on financial incentives, but it's very strong and active. It's called the Health Extension Platform. I will show it. It's really managed by health extension workers that are closer to families and communities and villages in Ethiopia, and provide help during pregnancy and delivery, and promote also health practices by families. And finally, in Nigeria, because we are working in a special place in the northeastern of Nigeria, the northeast of Nigeria, in a state called Gombe, we have a more conservative goal in Nigeria. The situation there is quite difficult. There are very few functioning health facilities. That's the culture is to deliver at home, and we think that we can help reducing neonatal mortality and maternal mortality to a lesser extent in northeastern Nigeria. So the first initiative is about technologies and tools. And at first, in 2009, and even before, actually, because there were grants and projects, of course, active before, the initial focus was neonatal sepsis, neonatal infections, and postpartum hemorrhage for mothers. 2 causes of death, sepsis for newborns and hemorrhage for mothers, that were considered urgent, important, challenging, but we have technologies to address them. More recently, we have expanded the work to include preeclampsia for women and preterm birth for babies. And we have also broadened the view. We run what we call an end-to-end approaches before making a decision. We want to know if we work to expand the use of a drug, whether that drug will be available, whether there are manufacturers interested in producing the drug, whether there will be budget lines in government budget, whether it will be implementable. Otherwise, it's not worth doing research that's not linked to a policy change and to solutions that are really feasible. So we have an end-to-end approach to technologies. And finally, we have also modeling and decision-making tools that we can explore in the question, if you want. Example of product that we are investing in, chlorhexidine for neonatal sepsis. That's an antiseptic that could be put on the cord once or several times during the postnatal care period. We are investigating the question, what is the mortality impact of chlorhexidine cord cleansing in community settings in 2 places, Pemba, which is in Tanzania, and in Zambia. Topical emollients, those are oils that are used to massage the baby's skin and protect the skin from infection. Antibiotics for neonatal sepsis, the regimen that is used at the moment is very complex. It's difficult to implement. It's 10 injections, intramuscular injections for a newborn, 10 daily injections of gentamicin. It's difficult. Can we solve the problem with a simplified antibiotic regimen and vitamin A for newborn? So the focus, as you know, the trend is towards simplification. Let's simplify the regimens and the interventions that are recommended because they are not implemented as they should. In the maternal side, we are working on oxytocin in different formulations. Oxytocin is a uterotonic, a drug that contracts the uterus, and it's widely used everywhere, but it's heat sensitive. The quality decreases rapidly when the product is exposed to light and to heat. So can we help producing heat-stable formulations? Can we deliver oxytocin with other devices? Misoprostol is also a product that contracts the uterus that is available in tablets, heat-stable tablets. So it could be in combination with oxytocin, a very important tool to reduce death from hemorrhage. The anti-shock garment is also a device that could be used to stabilize a woman who is bleeding, and I will show it. We have a study on this, and finally we have expanded the portfolio on preeclampsia by looking into prevention with calcium and treatment with magnesium sulfate and antihypertensive. So examples, and I will describe in more detail a few of those examples, particularly on the maternal health side. So here are those products. You see if we look at the maternal side, you see oxytocin as it exists now in vials. You have the misoprostol, which are tablets. The anti-shock garment is a sort of a suit that could be put on the lower body to really exert pressure and keep the blood flow to the brain and the heart while a woman is transported to a place where the postpartum hemorrhage can be stopped. Magnesium sulfate and blood pressure, for instance, you think that blood pressure is easy enough, but there are a lot of blood pressure cuffs that do not work. There are a lot of frontline workers that do not know how to take blood pressure, and what gets recorded in the medical register is not the reality very often. So simple problems like this take a long time to be actually investigated and solved. And then we have the product on the neonatal side. So I said that we are working more on preterm birth. This slide is really to show you the process that we follow. We built what is called an opportunity map. We look at the main causes of prematurity, infections, inflammations, nutrition, environment, and we, from that map, we select what we think are the better interventions that, not necessarily better only, but that are ready for investigation and implementation. And for instance, in the case of preterm, we have decided to focus on antenatal care corticosteroids, and that's something that also you also work on. So administration of corticosteroids to women in labor or prior to delivery is important for the fetal lung maturation and reducing respiratory distress in newborns. And another intervention called kangaroo mother care, which is keeping the baby on the skin, exclusive breastfeeding, and a lot of stimulation from mother to baby is actually quite an effective intervention, but it's difficult to implement it at scale. So we are actually focusing on those two interventions, and we are also investigating the other interventions that you see on the slide: neonatal resuscitation, a novel surfactant, infection, and in women, pessaries and progesterone, so maybe vaginal rings that would deliver progesterone. There are other interventions, but those are not ready for prime time, so they would be the focus of research projects and not implementation projects at this point. So I talked about misoprostol as an example. So again, misoprostol is a drug that could be used to prevent or to treat postpartum hemorrhage. And we have a number of trials and research projects going on comparing oxytocin intramuscular with misoprostol, investigating the safety of lower doses of misoprostol than the doses that are recommended. We work a lot with WHO, the World Health Organization, on the policy changes that should happen as a result of this. for each initiative, there is an advocacy and policy component. So again, the policy discussion that happens alongside the progress of the research is extremely important. Why misoprostol? Again, because it can be used at home by women themselves, and there are a lot of self-administration projects around misoprostol, a lot of distribution during pregnancy, and women could take the drug themselves after the delivery of the baby, and it's really working. So that's why misoprostol was of great interest for us, because misoprostol should be used in combination with oxytocin. You need several uterotonics in the maternal health programs in order to address the different types of PPH, the different places where women deliver. Oxytocin is difficult to use in small clinics and at home because it's an intramuscular injection and because it's not heat stable. So we work on misoprostol, as I mentioned, not only on research, but also on policy and advocacy around misoprostol in order to encourage policy change, to disseminate the evidence in peer-reviewed journals. We support the writing of papers and research findings, and we also collaborate with pharmaceutical entities to make sure that the misoprostol of good quality will be available. It's a drug that is available quite widely because it has different indications, including induction of labor, augmentation of labor, etc. But the quality of the manufacturing is often not good, so we also work with pharmaceutical companies. So what we know when we look at misoprostol for prevention of postpartum hemorrhage, we know that oxytocin is the preferred drug, but misoprostol can be used in rural areas. That misoprostol is now on the WHO Essential Medicine list for prevention, so it's important to also get a drug that works on what is called the EML list, the master EML list by the WHO, but also the essential medicine list in national context for countries. Misoprostol is safe, but we have still questions. So this is just to show that our projects usually have a research component, a policy component, and a development, pharmacological, pharmaceutical manufacturing component even. Misoprostol can be used also for treatment of postpartum hemorrhage when a woman, after getting a dose for prevention, keeps bleeding too much. And so there has been recently research on the efficacy of misoprostol for treatment of PPH, but we have to also work on the delivery model. So where should misoprostol be used, by whom, what is the level of the health practitioner that should use that drug? Can women themselves administer misoprostol not only for prevention but also for treatment, or should they be helped by a nurse midwife or an attendant at birth? What are the programmatic questions around misoprostol? Not only the medical clinical questions, but also the programmatic questions in order to deliver a drug that is potentially life-saving, but has also side effects, and that's why not a question, for instance, in the unanswered question is in many cases misoprostol has side effects, shivering and fever, but in a population in Latin America and in Ecuador in particular, in Andean population, the level of fever, the level of shivering was extremely high. So again, the question is there a genetic basis for this, and how can we investigate that question? If we move now from postpartum hemorrhage to preeclampsia is a complex problem also. Again, it's high blood pressure in pregnancy plus proteinuria, and it results probably from a default or from a defect in the way the placenta has been implanted and organized. And it's very dangerous for the woman, who can have fits and can have strokes, but also for the baby, whose growth is challenged, compromised, and who can also die in utero or soon after childbirth. We have an important portfolio of preeclampsia that covers many grants, and one is prevention. So we are investigating the administration of calcium during pregnancy, but also before pregnancy, in the few weeks before pregnancy. We are developing outcome prediction models to help frontline workers assess women, check women, and also decide which ones need to be transferred urgently to higher countries. And we will have a randomized control trial in 4 countries on that ID. And then we are also working on harmonizing biobanks and biodata and trying to do secondary research on those important and actually huge bio data sets that we have. And finally, as always, we have a knowledge translation and a policy and advocacy component. So the trial that I described, which we call the CLIP trial, community level implementation of preeclampsia management, will again help the community and the frontline workers and women themselves take the blood pressure, check the urine with a dipstick, and screen women, diagnose which ones are affected by preeclampsia and which one have to be transported urgently, which one can be transported non-urgently, and at the two facilities where, of course, there will be the full management of the preeclampsia, which includes administration of magnesium sulfate, administration of anti-hypertensive drug, induction of labor, cesarean section, depending on the case. So this is the first time that really preeclampsia will be looked after at the community level in small clinics, doing antenatal care in a very focused way. And we also actually are going to investigate the administration of magnesium sulfate and anti-hypertension medications at the point of care. So in small clinics, again, before the patient is transferred to a hospital. So those women will be treated earlier than the control women. And we will see whether it's possible to push management, detection and management of preeclampsia, or early management of preeclampsia, down the level of the health system, which is a kind of a new way of thinking and a very potentially influential one. In the future, we use cell phone a lot, of course, not only to check blood pressure, but to check oxygenation, and there is a lot of technology development around the initiative on preeclampsia. Finally, for this part of the presentation, we are working on dystocia, or obstructed labor. So we have an acronym, BOLT. I'm not sure it's the best one, but better outcomes in labor difficulty, and we are trying to address here difficult labor, which is another cause of maternal death. Difficult labor, which is a very complex problem to check because the onset of labor frequently is misdiagnosed. It's difficult to see how long a patient, a pregnant woman, has been in labor, through labor. We are investigating markers such as pre-connecting, diaphragms, ultrasound to predict or confirm labor. There are grand challenge explorations projects that are looking at belt that pregnant women could wear that would record contraction, tattoos even that would record vital signs. So we have a lot of investment channels that are what we call grant challenges or saving life at birth. Those are small grants of $100,000 to $1 million or $2.2 to $3 million that are really given to researchers and researchers teams that have wild ideas, crazy ideas. And it's crazy what we fund on this grant. Sometimes I feel like it's really, but sometimes it's very exciting. And of course, out of those many projects will be, some will be successful and will be game changing. So we are very excited about those channels for funding that are not big initiatives but small research projects on crazy ideas. And then we will develop a labor management tool that will help or replace, maybe in some places at least, the traditional cartograph, which is a graph that skilled attendants have to fill to monitor progressive labor, and which is often not filled, not used. At the same time, in this initiative, we are also looking at what communities think about labor, how they view labor, how they view obstructed labor, and there is a lot of social research and anthropological research that has to happen around labor and have happened already. But we will develop what we call passport for safe childbirth. So pregnant women a few weeks or months prior to delivery will receive a passport that explains what they have to expect and when they should be going to facilities. And then in facilities, we hope to improve the management of labor. Another examples of what we call Initiative 1 is the WHO Safe Childbirth Checklist Program. This is much less technological, much more programmatic. A checklist is a list of interventions that should happen to the pregnant woman or the woman in labor when she comes to the hospital for delivering her baby. So there are 4 pulse points on admission. The pulse point number 2 is just before pushing, so after what is called the first stage of labor, when the cervix is fully dilated, the baby is down, is really down the birth canal, it's okay to push. And then soon after birth, and finally before discharge. So there is a list of interventions, and the checklist used is designed in order to improve, of course, the accuracy of interventions that are being delivered, but also the teamwork, because somebody speaks aloud and lists the point, has the blood pressure being checked, has the, are you ready with a uterotonic to administer soon after birth? Did you wash your hands, etc. So you have a list of questions, 30 of them, across those 4 post points, that have to be implemented and checked. So we are going to investigate the use of checklists in hospitals in India. The checklist have been used, as you know, in the aviation industry, but also in many other places, including in bakeries, including in surgery. And for the surgical checklist has been extremely successful in reducing death in surgery in developed countries. So we feel that its application to childbirth is a very important thing to investigate. So we will uncover systems malfunction and increased communication and facilitate dialogue. We had a pilot project that was very successful in India, and we are working now on a randomized control trial in Uttar Pradesh in India with 45 interventions facility, 45 control facilities, and we will investigate the impact of checklists on maternal mortality, maternal mobility, but also perinatal mortality and mobility in those. So initiative 2 and 3 are not on technologies, but on frontline workers and demand for families and communities. So we work in 3 countries, as I say, India, Nigeria, and Ethiopia. I will not talk about Nigeria. I will talk only about Ethiopia and India. And I will check the time, because I want to make sure that we have time for questions. So I will probably move a little faster. But I just wanted to illustrate what we do in terms of those initiatives 2 and 3 that are more programmatic in nature than the first one, which is really research. But you have seen research of very different types. There are really research on drugs, but research on program, checklists, for instance, etc. So we wanted to address the problem that is illustrated by this slide, which is often there are research projects that are extremely sophisticated and successful. Those are the inputs, but they cannot be translated into program at scales in country, because the implementation part is not being investigated sufficiently, or the intervention is not feasible. So that's the black box of implementation. The examples of innovations that we are working on with frontline workers and communities, again, strengthening demand, initiative 2, and helping frontline workers, initiative 3. So in initiative 2, for instance, we are working on community engagements through media campaigns, conversations with family, women's groups. That is a very effective intervention that has been proven to be effective in South Asia, in particular India, Bangladesh, Nepal, but is also active in Africa. And then strengthening the capacity of local civil society organizations and of professional associations, obstetricians associations, pediatricians associations, nurse midwives associations. In terms of frontline workers' performance, we have checklists that I talked about. We have programs that are trying to strengthen the effectiveness of training system by organizing in-service training, mini labs, capsular training, focusing on one complication at a time. All sorts of different pedagogical interventions that are different from the traditional training. We are also helping partners implement incentives, financial and non-financial. We are helping policymakers, in particular district managers, understand data and use data for improving the programs in their areas of influence. We are working on supervision and coaching models there is an abundant literature on this, and many organizations and institutions are working to improve supervision, and it's hard. And of course, we are working on animal health as well. We have also two particularly interesting programs in Ghana and Ethiopia looking at referral systems. So the transportation of a sick mother or a sick baby or a sick child from the place where that patient is to a hospital where they can receive care is a major problem. It doesn't work. It's really often the patients and her family or his family goes to another clinic, private clinic. They don't have transportation. There is nobody at the clinic to provide care. It's a major problem to investigate what we call active referral systems. Ethiopia, a picture of Ethiopia that says it all. I think Ethiopia is a place where transportation and geographic access is a major problem. It's a beautiful country, but very difficult to work in there. Ethiopia has an important disease burden, disproportionate vis-à-vis their share of the global population, which is 1.3%. You see it at the bottom of the slide. And then maternal, they are the home to 4.2% of maternal deaths in the world and 3.5% of neonatal deaths in the world. The health system in Ethiopia, of course, has a top layer which is formed of hospital, specialized hospital and primary hospital, but the bulk of the system is based on a platform that is called the Health Extension Platform, HEP platform, and that is composed of small health posts and then bigger health centers. The small health post has 2 or 3 attendants that are health extension workers. They are trained for, I think, about 18 months or 1 year, and they deliver immunizations, they deliver counseling, they deliver nutrition and water and sanitation counseling, and they're supposed to attend childbirth, but they don't attend many deliveries. And the health center is manned with a full midwife that can attend deliveries. So the responsibility of the health extension workers are extending, actually, and really trying to include antenatal, postnatal care, and again, those are the list of the responsibility of health extension workers in the hygiene and sanitation areas, but also in family health. They also provide family planning and more so. So it's really a primary health care, vast and strong primary health care program. From the interventions that we have been implementing and supporting, when I say we, of course, I mean not the foundation really, but the partners, our grantees, our partners, the organizations with which we work, and it goes from government to national implementation agency to academic institutions and research teams. So what has happened in Ethiopia, as you can see over the last about 3 years, is that from a baseline in red, a midterm review, and now a new survey has shown increase in the number of antenatal care consultations, 4 consultations per pregnancy. So we have increased the number of interactions between frontline workers and families. The iron supplementation is better, tetanus toxoid is better, and counseling about birth preference is better. So we see an improvement. We don't see yet its impact on maternal and neonatal mortality, but there is here, the health extension workers, as I said, attend very few deliveries, 4% at the beginning of this program, now 11%. Skilled delivery by midwife has increased, but slightly. Postnatal care is better, from a very low baseline of 1% is now 9%. And any prenatal care in the first 2 days after birth, but any postnatal care days after birth, but any postnatal care has increased to an extent that is still not satisfactory. 30%, 1/3 only of mothers and newborns are being checked after birth, but as in India, we work in the north, as I said, and this is sanitation. This is not maternal and neonatal care, but I think it illustrates well the difference between the poor and the rich in India, in this case, in terms of access to sanitation. And that the same goes for maternal and neonatal care. Again, India, huge place, 20% of the global births, but also 20% of maternal deaths happen in India, and almost 1/3 of neonatal deaths in the world happen well, and particularly in the 2 states that are on the left-hand side of the graph, UP and Bihar, are really states where a lot of the population live and a lot of the maternal and neonatal deaths take place. You see the number of people in Bihar, 83 million, 38 districts, but there is in Bihar a very good chief minister, a very good government for the last 4 years now, and we have seen a lot of emphasis on and this allocation of resources on health and education, and it's really starting to show results. In Uttar Pradesh, where the population is even bigger, 200 million people, there is since last year again a new government for the state of Uttar Pradesh with a very effective, more technocratic government, and a lot of and a firm commitment to improving health and education. You have then the now, but I just wanted to show you only the left-hand column. So the interventions that we are implementing together with the government in Bihar. So again, preparation for birth, management, better management of deliveries, improvement of the quality of the care provided in those clinics, a better postnatal care, and a better referral package for women and babies who need transportation. So we have again tried to agree on a relatively short list of interventions that should be provided. But we work in Bihar, we work on many other aspects of the health system, including working with private providers as well as with public providers, working on the system for providing incentives, financial incentives to families and frontline workers. So we work with the World Bank on that. We work with the BBC World Trust on media communication, and we work on with communities. So this slide is to show that when we build a big initiative like the one in Bihar with the government of Bihar, it's not only supply side, it's not only working with midwives and doctors, but it's also working with media and communicators, it's working with the World Bank and health economists that are working on financial systems, it's working with the government, it's working with communities, it's really working from different angles, all of this being relatively coordinated. It's hard, but it's happening more or less, relatively coordinated to achieving the same goal of reduction of mortality and improvement of health. Some results in Bihar that I will go quickly through because they are very visible, I think very clear. More home visits during pregnancy. Again, checking, assessing the quality and the number of interactions between frontline workers and families. More mothers, but not many, but more mothers receive information than signs. Mothers deliver in facilities. The difference is less important because there was already a big push for facility-based births in India, so the program did not increase the number to a great extent, but is increasing the quality of care delivered in those private and public facilities. Home visit after day 1 or within day 1. Home visit during week 1, so from 6 to 23%. Receiving some advice in the postnatal care period. Number of newborns who got nothing on the cold, rather than cow dung or something that could provoke an infection. Nothing is better. Chlorhexidine would be even better, but it's not, we are not there yet. Breastfeeding within 1 hour, so immediate breastfeeding. And again, the principles of our approach is to work on from different angles with different partners and to also contribute to the collaboration between different partners. Finally, Initiative 4, and I think I will go relatively fast on this one, though Initiative 4 is advocacy delivery, is working with groups like PMNCH, the Partnership for Maternal Newborn, the platform for collaboration between organizations that work on those issues, is working with Saving Newborn Lives that really focus on neonatal health, working with organizations like Women River and professional associations. And there is one group that is called the Maternal Health Task Force that's based out of Harvard and is really creating a space for discussing maternal health issues and helping young professionals also access maternal health training and really developing maternal health programs in countries like India and Ethiopia as well. The maternal health task force is also used when there is a discussion, a topic for discussion that affects maternal health and another group, for instance, malaria and pregnancy. We brought together the malaria community and the maternal health community to try to improve the prophylaxis, the malaria prophylaxis during pregnancy, and the maternal health can happen. This is the website. The Maternal Health Task Force organized in January of 2013, so 2 months ago, a big conference in Tanzania focusing on quality of care at childbirth, and that's also a role for that Maternal Health Task Force is to organize every 2 years the only global conference on maternal health. PMNCH is more, as I said, a platform. I think I will pass it on. And then we also have a grant that called IDs that evaluate that strategy. So I talked about the strategy, I talked about the grants, but is it working? We really wanted to know whether it was working, and therefore we gave a sizable grant to the London School of Hygiene and Tropical Medicine to go to those countries, Ethiopia, India, Nigeria, and ask the questions. Are we improving the interactions between frontline workers and families? Are we helping to reducing maternal and neonatal mortality? And if not, why is that? And if yes, what are the ingredients of success? And I've showed the result of some surveys, but those surveys were conducted by the grantees themselves. This is another grantee that is providing an external view, an external assessment on the strategy, and it's work in progress. We are not we are in the middle of this, but it's really an interesting way of checking and maybe recalibrating or readjusting our theory of change, which is again that through innovations we will improve interactions, we will improve the coverage of interventions, and we will have an impact on health. I think I talked about that, but I wanted to mention this, which is the time gap between an idea and its implementation in a country. It's a long time. It's often 10 to 15 years, and we would like to shorten that length, that duration. duration, that time frame, in order for good ideas to be available in countries within 5 to 7 years instead of 15. And that's something that we are very keen about. Finally, we are looking at urban places. You know, of course, urbanization is growing, and that urban poor women actually sometimes fare less than rural poor families. Sometimes the geographic access doesn't mean financial or cultural access. There are a lot of poor people living in slums who do not go to hospitals, and we want to also look at that problem. At the same time, maybe it's less the problem in Latin America, but in many places in Asia and Africa, the municipalities don't have a strong health program. They don't have health experts. They really, those are wide spaces in terms of health structures, and all the programs are in rural areas. We are therefore thinking of changing the strategy to some extent, or making some adjustment to it, including in focusing more on quality and continuity of care, so working maybe with higher level, at least district hospitals, not higher than district, but working with facilities, not only with communities and first level clinics, thinking about the content of antenatal and postnatal care, not only the contact, but what is happening during that contact, engaging with the private sector. Private sector is providing a fair amount of care in many places. We don't work enough with private providers. Exploring urbanization and working in urban context, and making sure that we have strong linkages with the family planning and of course neonatal health programs with maternal health, and also changing endpoints from mortality to morbidity, for instance, because mortality is decreasing, it's a good thing, but then we may want to look at morbidities and at composite indicators and process indicators rather than having mortality as. This is the last slide. So after the conference in Tanzania in January, there was a manifesto was issued for maternal health. Because I know you cannot read this, but you will read it in the Lancet if you want to. And it's interesting because it's starting to think about what will happen post 2015. What is going to happen after we assess the Millennium Development Goals? What are the Millennium or the Sustainable Development Goals? What is the place for health within that set of Sustainable Development Goals that are being discussed now, and for maternal health and neonatal health? Will it be there, and so on what form? And I think that's an interesting discussion, an important discussion, which is linked to the discussion that I mentioned at the very beginning about the end game for maternal and neonatal mortality is in sight, and that's very exciting. I am happy that I spent my life on maternal health because it was considered a failure for a long time. It's now seen as somewhat of a successful area of work, but a lot needs to be done. So I'm